All right. Hello, everyone. I'm Jason, or Sen, given the what I've put on the presentation. Can I just make sure that people can hear me if they can put something in a chat? It's my first time doing this, so I'm anticipating quite a few hiccups along the way, but hopefully not too many. I know it's due to start at 7 o'clock, but I think we will just wait for a few minutes so that people can join, or when people do remember that they did sign up for it. Thanks, Dayo. All right, I think I'm going to start, otherwise it would be very unfair for those who did show up on time. So let me just get my slides ready. So yeah, thanks everyone for coming online. It's your Thursday evening, so I hope not to take up too much time of yours. So I'm Jason, one of the Foundation Year 1 doctors in Gloucestershire, and I'm quite interested in ENT. That's why I'm speaking to you about this. So we'll be going through hearing loss and audiogram interpretation today. And from the survey results, it looks like ENT is not a very well covered topic in a lot of medical schools. And I remember in my medical school, we had very little ENT exposure as well. And I think I practically learned all of my ENT on PassMed and QuestMed. So I just hope to go through some of the points that I've found helpful in my ENT placement and what I've picked up in my ENT electives, and hopefully to provide you guys really with a set of tools to go through an ENT history and to be able to interpret very common ENT examinations and investigations to reach a right diagnosis. So moving on to the topics covered. So firstly, I would like to go through a little bit about the basic anatomy and physiology of hearing. So bring you guys back to sort of first year and second year physiology lectures, just to sort of bear in mind where the problem would be in different presentations. And I've always found it useful to have that in mind when I'm able to link the anatomy to the pathology. And next, we'll go through very common differentials and how do we actually assess them as if we're in a ENT hot clinic. So we'll go through history and examinations and how do we interpret those. And lastly, we'll go through the pure tone audiogram, which is the most common audiogram that you'll find in exams and in OSCEs or whatever that's called now. That really shows my age in terms of when I've trained. All right. Is there any questions from anyone? If not, I think we should just begin. Sorry, I have to jump back and forth because the chat disappears when I present. All right. So starting with the basic anatomy of hearing, the ears are divided into three main parts. So the outer ear, the middle ear, and the inner ear. The outer ear contains what we can see from the outside, which is also called the pinna, including all of the external acoustic meatus and ends at the eardrum or the tympanic membrane. The middle ear consists of the tympanic membrane and these set of bones, which we collectively called ossicles, and ends where the stapes footplate meets the oval window here in the inner ear. And basically the inner ear contains all of the sort of sensory organs that converts kinetic energy from sound waves to electrical impulses that our brain perceives. So moving on to a closer examination of the middle ear and the inner ear. So we've got the tympanic membrane here, which is the start of the middle ear. And we've got this set of bones that I have mentioned. It's called the ossicles, which is made of three main bones. We've got the malleus, the incus in the middle, and we've got the stapes. And for those who have already been taught how to do an otoscopy, you will probably remember one of the landmarks that we look for is the handle of the malleus, which is here, which is attached to the tympanic membrane. So the sound would be hitting the tympanic membrane, cause it to vibrate, and that vibration is amplified through this chain of bones, and ultimately reaching the stapes, which is also the smallest bone in your body. And the stapes is attached to the oval window that's here. And then we've got the inner ear, which is made of the cochlea, which is responsible for hearing. And we've got the three sort of semicircular canals that's responsible for balance. So I thought it would be useful to go through the chain of transmission within the sound, and just as I've asked you guys to answer in the quiz, in the registration. So when the sound waves goes through the tympanic membrane, through the ossicles, and hitting the oval window, which is sort of the opening of one of the openings in the cochlea, it causes vibration of this liquid called perilymph that's contained within the cochlea, and it sends vibration all the way down throughout the cochlea, causing the membranes within the cochlea to vibrate as well. And the round window here, which is the other opening of the cochlea, is able to expand, and this allows the wave of fluid, the motion of the waves to occur within such a tiny structure. And so how does all of that get converted to a electrical signal? It's down to the hair cells within the cochlea itself. So if we cut the cochlea into a cross-section, you'll find three main compartments that's separated by different membranes. So we've got the scala vestibuli, scala media, and scala tympani. And within scala media, it contains this structure called the organ of Corti, which is the sort of the sensory organ that converts the kinetic energy from the sound waves to electrical signals. So if you look closer at the hair cell, which makes up the organ of Corti, it's got a very funny looking structure, which is very specialized. So this whole thing, I hope you guys can see my cursor, is called the hair cell. And what's sticking on top of that is called the stereocilia. It's a bit like the cilia that you find in the gut mucosa. And what's on top of these stereocilia are these mechanically gated ion channels that allows potassium to come in. So when the stereocilia moves as a result of the sound waves, these mechanically gated ion channels actually opens when the stereocilia moves. And that causes an influx of potassium from the perilymph into the hair cells, and ultimately causing a release of neurotransmitters when the cells is depolarized, or the inhibition of neurotransmitters being released when the cells is hyperpolarizing. And that ultimately changes the kinetic energy into electrical signal that our brain can interpret. And I hope by going through the anatomy of the ear, I really hope to make you guys appreciate how delicate the structures are within the ears, and therefore how easily damaged they could be by noise pollutions or ototoxic drugs. So moving on to assessing common differentials of hearing loss. But actually, before we do that, if you guys have any questions, please just pop them in the chat, and I'm more than happy to answer all of those questions. And I hope to finish this talk in about half an hour's time, so we have some time to go through the questions. Right. So in this part, we'll go through the history and the common examination that we do when a patient comes into a clinic presenting with hearing loss. So how to take a hearing loss history. One of my good friends gave me a really good tip during my OSCE. He said it's always very important to understand the context and chronology of the patient's presentation to get a really good idea of what the patient has been through themselves before coming to seek medical attention. So it's basically like taking, for example, a pain history using your Socrates. So asking very useful questions such as, when did the hearing loss start? How long has that been going on for? Has that gotten better or worse? And It's also important to get a bit of a history on what was the patient doing when the hearing loss started. Was the patient experiencing, did they wake up with a hearing loss, or did they unfortunately hit their head over something, that they fell down a mountain, which is actually a case that I saw, which resulted in a fracture within the temporal bone, cutting straight into the cochlea, which ultimately resulted in sort of irreversible hearing loss, unfortunately. For pediatric history or elderly patients, foreign bodies could be a cause of hearing loss. Any habits of evacuating earwax could be a very common cause of hearing loss. Any recent air travel or diving, which could point towards barrel trauma that results in a perforation of the tympanic membrane. Any recent infections, which we'll talk about later, and any occupational exposure to excessive noise. Did they work as a mechanic somewhere? And just like in a very common pain history, associated symptoms, very useful for us to get an idea of which diagnosis would be more possible. So things to ask includes, when they have this hearing loss, have they noticed any discharge? How does it look like? What sort of discharge is it? Is it clear? Is it bloody, or is it sort of quite murky and foul smelling, which points to a particular diagnosis? Has there been any pain, otalgia, and tinnitus, which is a very common associated symptom with hearing loss? Any vertigo or nauseousness, which can point to sort of further involvement of the semicircular canals. And some important reflex to notice in a hearing loss history, which is quite important to bear in mind in any history. So any recent trauma, which will then require sort of urgent surgical intervention. And since meningitis could present as hearing loss, so any systemic symptoms that might suggest meningitis, such as feeling generally unwell, fatigue, having a fever, headache, photophobia, neck stiffness, and any facial weakness, which can point towards a sort of neurological cause of hearing loss, or sort of surrounding nerve involvement. And last but not least, a good medication history and surgical history will be very beneficial in this context. So any recent antibiotics, any loop diuretics, which can contribute to hearing loss, and any recent ear surgery, which could warrant quite urgent attention as well. So in terms of examination, there are a few bits that you'll want to cover. So a sort of general ear examination, looking at the outer ear, if there's any sort of obvious deformities. A cranial nerve exam will be very helpful to discern if there's any other potential sort of involvement of other cranial nerves, and especially with the facial nerve, the seventh nerve, because it sits quite closely to the vestibulocochlear nerve in the brainstem. And it'll be useful to test their hearing grossly, so how well they can hear whispers by masking the other ear. And the Rennie's-and really the notorious Rennie's-and-Weber's test that we'll go through in just a moment, and otoscopy, which is quite useful to discern if there's any pathologies within the external acoustic meatus or the tympanic membrane itself, which I've always found is quite a difficult skill, and no sort of ear canals look the same. Some can be quite sort of bendy, which is quite tricky. So, I've always found Rennies and Webbers quite confusing when I was first taught this. But what I've realized over the years is that it's actually a really, really simple test, and I hope this presentation will be able to clear any sort of misunderstanding or confusion that you might have with Rennies and Webbers. So traditionally, we perform the Rennie's test first, and then the Weber's test. And I'll just go through how do you perform these tests exactly. So ideally, you'll want to get a tuning fork of 512 hertz. And I remember in my medical school, they used to try to confuse us by placing a few different tuning forks, especially the 128 hertz and the 512 hertz in the same box. And how I've always remembered it was that comparing to a longer 128 hertz tuning fork, it's probably less painful to insert the shorter tuning fork into your ear. So that's why that's the one to use in Rennies and Webbers. And the reason why we're so particular with the 512 hertz tuning fork is because of the acoustic decay of the tuning fork. Given the high frequency, the decay time is very, very, very long. So it's very helpful for us to check the air conduction ability of the patient. So what you would do is to ring the tuning fork on your elbow, or you try to pinch the ends of the tuning fork together. You place the end of the tuning fork at the patient's mastoid process on one side, and you ask the patient to let you know when they can no longer hear the vibration or the sound coming from the tuning fork at the back of their head. And once that they tell you they can no longer hear from the back of the head, bring the tuning fork right next to their ears and ask them if they can hear the ringing that's transmitting from the tuning fork to the ear. And if they are able to do that and tell you that they can hear the tuning fork when you bring the tuning fork back to their ear, that will suggest that the air conduction is better than the bone conduction, which in technical sense is a positive Rennie's test. Okay. So you do that for 1 year, and then you move on to the other year. Okay. I'm aware that this is probably a bit confusing. Does anyone have any questions about this? Okay. So if there's no question, I would move on. Or if you guys have any parts that you're confused, I'm happy to talk over it again at the end of the talk. Okay. So that's Rennie's test. It helps us to discern if air conduction is better than bone conduction. And in Weber's test, it's a bit more straightforward. So you still use the 512 hertz tuning fork, and you ring it, and you place in the middle of the patient's forehead, and you ask the patient which ear they can hear the ringing better. And if they say their right ear is better, then you would describe this test as the Weber's test then lateralizes to the right. However, if the Weber's test is on the same, is the same on both sides, then you just say there's no lateralization in Weber's test. And at this point, you might be wondering if the Rennie's test can tell us whether the air conduction is better or the bone conduction is better. Why do we do a Weber's test? Because actually, in the Rennie's test, we're able to discern the two main categories of hearing loss. Is it conductive, which means there's a blockage among the transmission of sound somewhere from the outer ear all the way to the end of middle ear? Or is it a nerve problem? Is it a cochlear failure, or is it a sort of cranial nerve 8 vestibular cochlear nerve problem? But in the context where there's actually a sensory neural hearing loss, for example, in the left ear, the Rennie's test for that ear would be that the bone conduction would be better than the air conduction because the nerves is just not working. And it would be a false negative Rennie's test because the bone conduction is actually transmitted to the good ear, which is the right ear. So then you need Weber's test to figure out whether it was a true conductive hearing loss, or is it actually a sensory neural hearing loss? There was a long string of argument to follow, so I hope that was clear. I think it'll be clearer if we're able to go through some of the cases later. Yeah, so that's basically the rationale between the Rennie's and Weber's test. So just to go through things again, so Rennie's and Weber's tests help you to discern whether the patient is experiencing conductive hearing loss or sensory neural hearing loss. Is it nerve failure or sound transmission failure? And a sound transmission failure means the nerves in that ear experiencing hearing loss is still working perfectly. It's just that the sound is not able to get to the cochlea. So the Rennie's test help us to identify which ear has better air conduction, which is the normal way of hearing, and it will help us to identify if the ear has any conductive hearing loss. But in the case of sensory neural hearing loss, you will have a false negative Rennie's test because the nerve is just not working. So there wouldn't be any perception of sound when you bring the tuning fork to the ear. So that's where the Weber's tests come in. So if we move on to the next slide, I've really just put it in because I just thought the diagram is really trippy with the eyes. So when a Weber's test come in, if the patient has sensory neural hearing loss, their bone conduction would be better on this ear as well. But when you do the Weber's test, it will lateralize to the good ear, the ear that's working. So it will help us differentiate whether that's a true conductive hearing loss or a sensory neural hearing loss. And counterintuitively, I think that's why Rennie's and Weber's is so confusing. A conductive hearing loss in a Weber's test actually sounds louder in the bad ear where conductive hearing loss is happening. So in this case, in a conductive hearing loss here, the bad ear would have a negative Rennes where the bone conduction is better than the air conduction because the transmission of sound is bad. But counterintuitively, the Weber's test sounds louder in the bad ear. And there are a few theories behind that. One of the more convincing one that I've read is that, let's say you have got a tumor or like a cholecystoma growing in the ear canal. It creates this sort of echo chamber when Weber's test is performed, and therefore reinforcing that noise transmitting to the cochlea. So yeah, so that's Rennie's and Weber's test, which is really helpful in discerning conductive versus sensory neural hearing loss. Okay, I'll go through any questions of Rennie's and Weber's at the end. I hope that was clear enough. So moving on to audiogram interpretation. I think really the key is to understand the layout of audiograms. So on the y-axis, the vertical axis, we've got hearing levels measured in decibels, which means how loud the sound needs to be for the patient to perceive that sound. And down on the horizontal axis, you've got frequency. And I think it's quite important to sort of learn the keys of audiogram. So for air conduction, it's dots and crosses. So I've always struggled to remember it. So to me, the right is always a dot or a circle because there's more curves in R, and X is always left because L is more sort of angular. I think that might be helpful to remember. So that represents the air conduction of the right and left ear, which will be plotted there. And the bone conduction is always plotted by things that shapes like brackets. So just to start off with an example. So we've got dots and crosses here, which means it's a diagram showing us air conduction of the left and right ear. And I've made this audiogram, which is supposed to represent normal hearing. So across all frequencies, the patient is able to hear within sort of 25 decibels. So from 0 to 25 will be considered as normal. And how these tests are actually conducted is the patient will be wearing earphones in a very quiet room, and the audiologist will be playing sounds of different frequencies, and we will ask the patient to press the button when they are able to first perceive that sound, which give us these markings. So that's how it's sort of a subjective reporting from the patient, but that's one of the best tests that we have. So moving on to another sort of audiogram, we've got dots and crosses again. So those are your air conduction, and we've got a funny looking bracket here which represents bone conduction. So here we can see the right air conduction is significantly worse than all of the other markers here, which suggests there's a moderate hearing loss in the air conduction of this patient. So what this really means or represents is that there's an air bone gap, which is suggestive of what we call conductive hearing loss. Okay, so it's a bit like a visual representation of the Rennie's and Weber's, where the patients would always report that bone conduction sounds better, and then when it's through their ears, the transmission of sound is not getting to their cochlea. That's why they are reporting they will need a higher amplitude, a higher energy to hear through air conduction. So that's a very classic looking conductive hearing loss audiogram. So I hope that's helpful. So just a bit of recap. The horizontal axis represents the hertz, the frequency of the sound, and the vertical axis represents the sort of how loud the sound is in decibels, which is how loud it needs to be for the patient to hear it. And the dots and crosses, the right ear is always a dot or a circle. The left ear air conduction is always a cross. And for bone conduction, it's always some sort of bracket looking thing. And yeah, I guess it makes sense. It looks like the right ear and the left ear. Okay. So moving on from audiogram, I thought it would be useful to go through some cases before we finish. So let's start with this word I can never pronounce. I'm going to try. So prebiscusis is a very fancy word for age-related hearing loss, and it's always thought to be due to cochlear hair cell degeneration and the loss of auditory nerve fibers in cranial nerve 8, the vestibular cochlear nerve. And as you can see in this very nice electron microscopy diagram or image, these hair cells are so delicate, you can imagine how easily they could be damaged with very loud, high-energy noises. So given the etiology of this disease, it's a type of sensory neurohearing loss. And going back to the history taking, how do we actually reach this diagnosis? So these patients often present older, and often 60 years old is a cutoff. It's often a bilateral progressive hearing loss, so it doesn't really get better with time. If anything, it gets worse. And it's often bilateral because the amount of noise damage is the same across both years, usually across time. And one of the more interesting thing you can ask the patient or their family members, because that's often who first notice when they're turning on the TV or radio a bit louder, is that they have really it's really challenging for these patients to hear you when they're in a very noisy environment, like in a coffee shop or in a tube station. And it's actually one of the more prominent signs for age-related hearing loss. And it's often associated with tinnitus, so ringing in the ears. And risk factors to explore with the patient includes occupational exposure, like we've talked about in the beginning of the talk, and any recent or past medical history of ototoxic medications. So moving on to another type of hearing loss that comes to the clinic quite often, it's SSNHL, so the sudden sensory neurohearing loss. There's a big debate on what actually causes it. Some people theorize that it's a bit like a TIA, where there's a transient sort of embolic or blockage of the terminal arteries that supplies the cochlear nerve, resulting in nerve failure. And some theorize that it might be due to viral infections like mumps, or it could be an autoimmune process, a little bit like optic neuritis and MS. So in terms of the context and chronology of patients who present with sudden sensory neurohearing loss, as the name suggests, it's a very sudden and often unilateral hearing loss. So often patient presents after they wake up and noticing that they're deaf in 1 year. Most common age group is between the 40 and 50-year-olds. And it may be associated with tinnitus. And it's quite important to get this diagnosed very early on with an audiogram. So we use the rule of 3 to diagnose this hearing loss, where the hearing loss has to be of greater than 30 decibels in 3 consecutive frequencies. And given the name of this disease, the onset has to be within 3 days. And the reason why I've put a Cochrane Review logo here is because it recommends to commence these patients on high-dose steroid, like 60 milligrams. However, when I looked into the Cochrane Review done in 2013, it only had 3 randomized control trials, and only 1 showed statistically significant benefit in providing steroids. So the evidence is actually a bit mixed for this disease, but the recommendation is to give these patients high-dose steroids. And I'm guessing it relates to the autoimmune process in this disease. So moving on to 2 sort of tumor-related cause of hearing loss that I thought can be quite confusing for some people. So we've got cholesteatoma here on your left, and we've got acoustic neuroma on your right. And they're both abnormal growths, but they result in very different pathways resulting in the hearing loss. So talking about cholesteatoma first, it is a uncontrolled growth of squamous cell epithelium starting really in the external acoustic meatus that erodes through the middle ear and to the mastoid air cells in the temporal bone. And because of this erosion and invasion into the middle ear, patients often present with chronic or recurrent middle ear infection, a lot of pain and discharge, and the discharge is often sort of foul smelling, as I've written here. And it is often a unilateral disease, so patient will be describing a unilateral progressive hearing loss. And what's really useful in these patients is to take a look into their ear canal using otoscopy to look for any signs of cholesteatoma. And on the other hand, we've got acoustic neuroma here, which is a tumor that arises from the myelin sheath of the Schwann cells in cranial nerve 8, the vestibulocochlear nerve, in this region of the brainstem. It's called the cerebellopontine angle. So that's the pons, and that's where it connects to the brainstem there. The best imaging modality for suspected acoustic neuroma is actually MRI. So this is a T1 image where the fats actually light up. So the common sign is called the ice cream cone sign. I'm not sure if you guys can appreciate that, but it's often round on the top and sort of triangular at the end. And given the proximity of cranial nerve 8 to cranial nerve 7, we look for any sort of signs of systemic involvement. So it might be associated with facial weakness or numbness, when it also affects the trigeminal nerve. Patients often present with headache, as this is a tumor that's growing in their head. And given the cerebellar involvement, patients can often present with ataxia, so imbalance in their walking as well. So it's often unilateral progressive hearing loss as well. And just on a side note, patients that present with bilateral progressive hearing loss that's found to be acoustic neuroma is very suggestive of neurofibromatosis 2 NF2, which is a hereditary condition. So those are the 2 sort of tumor-related causes of hearing loss. And next, we have otosclerosis, which is a very interesting disease. So you probably remember this diagram is the middle ear, and your inner ear, where the stapes here connects to the oval window. Otosclerosis is a disease of abnormal bone growth of the stapes footplate, causing fixation onto the oval window, and it ultimately results in inability for the stapes to transmit sound from the oval window into the cochlea anymore. So it's a type of conductive hearing loss as it's preventing the transmission of sound. And it's often a progressive unilateral to bilateral hearing loss over many, many years. And in terms of epidemiological data, female are twice more likely to experience otosclerosis than men. And there have been anecdotal evidence or reports that these hearing loss worsens during pregnancy due to hormonal involvement. And it's often a question that you can ask if you're suspecting otosclerosis, if a young patient presents with these symptoms, if they've had previous pregnancy, and if they have noticed hearing worsening during their pregnancy. And given the nature of this disease, there's often a relatively strong family history. One of the associated symptoms could be vertigo in otosclerosis. And what they actually do to fix otosclerosis is actually quite clever. They use lasers to burn off these articular points of the stapes here, where the stapes connect to the incus, and around the oval window using laser. And then they put in a artificial prosthesis that replaces the stapes to continue to transmit sound to the oval window. And patients often report hearing instantly becoming better after surgery. So quite a really good surgery. So last but not least, some of the medications and infections that can contribute to hearing loss. So some of the ones that I've come across so far in my very short F1 career is actually loop diuretic when I was on cardiology, aminoglycoside and macrolide antibiotics, so your gentamicin, amikacin, your erythromycins, platinum-based cytotoxic chemo agents like cisplatin, anti-malarial drugs as well. And really for medical students that are in their final years or going to be F1 very soon, ototoxic is a horrible side effect of these medications, but it's not really a strong contraindication for these medications. If they are in heart failure, then they need to be offloaded, was to give the furosemide. But as incoming doctors, it's quite useful to think about how do we actually reduce the risk of ototoxicity in these patients. So for example, furosemide, the higher the dose, the more likely they will be experiencing ototoxicity. And you can think about a continuous infusion using IV instead of boluses, which is actually better in preventing ototoxicity. And for things like antibiotics, monitoring GENT levels is quite important. And there are other implications as well, like renal impairment. Infective causes could contribute to hearing loss as well. So acute otitis media and acute otitis externa, labyrinthitis, which is a result of viral infections normally associated with vertigos as well, and meningitis, as we've talked about. Yeah, so that's the end of my talk. These are my references, usually for all the beautiful drawings that I've referenced here. So not too bad with the time, actually. All right, so I hope I've not bored you guys. Does anyone have any questions at all? Okay. I thought it might be fun to do a little quiz, if you guys don't mind. So if you guys can use your phone to scan the QR code, or if you go to menti.com, put in chat. And the login code should be 65322215. I really hope this works. So we'll see. How would I know if... Let's see if the code works. 6532. Okay. Give me 1 second. All right, I'm not really sure if that would work, unfortunately. All right. Then, since I don't think the quiz is working, I think that will be the end of my talk. Thanks everyone for your attention. And if there's anyone that has any questions, I'm happy to answer at the end. If you guys can fill out a feedback form for me, that'll be greatly appreciated. It's a link down below. And yeah, I hope I've not confused you more than before the talk. Oh yeah, I see. Okay, yeah, I think I'll try the quiz next time. Okay, and yeah, if you fill out the feedback form and have any more questions, feel free to log off, and have a good Thursday evening. Thank you guys for attending. I'm going to stay on to 8, just in case if there's any last minute questions.